Welcome, everyone. This module provides information about opioid use disorder, or OUD, treatment and recovery. In order to understand the various treatment options, it's important to better understand how and why OUD is considered a chronic disease. A lot of effort has been put into this module due to the overwhelming stigma associated with not only OUD, but the treatment methods as well. Before we begin, though, I'd like to introduce you to the project team responsible for the development of this 5-module toolkit. The following Montana State University faculty and staff helped create the content and graphics of this toolkit. Myself, Michelle Grokey-Dewey, and Allison Brennan served as principal investigators. I am the Health and Wellness Specialist with MSU Extension, and Allison is the Mental Health Specialist. Our team is led by Program Director and MSU Extension Associate Specialist, Barbara Allen. Other MSU Extension employees responsible for the content you are about to see include Barbara Watson, Program Coordinator, and Lowry Mayer, FCS Administrative Assistant. Today you'll be listening to the bonus module of our toolkit. This project was funded by the Substance Abuse and Mental Health Administration Grant, Prescription Opioid Awareness, and the U.S. Department of Agriculture. At the conclusion of this module, participants will be able to better understand the cycle of opioid use disorder, learn more about the origins of medication-assisted treatment as well as the FDA-approved medications used to treat OUD, and understand the difference between opioid treatment programs versus office-based opioid treatment programs. It is very important to remember different levels of OUD treatment may be needed by different individuals and/or at different times. This can encompass everything from outpatient counseling to intensive outpatient treatment, inpatient treatment, or even long-term therapeutic community involvement. Opioid use disorder often requires continued care to be effective. Evidence-based care for opioid use disorder involves several components, including the following: personalized diagnosis and treatment planning tailored to the individual and family, long-term management. Addiction is a chronic condition with the potential for both recovery and reoccurrence. So with that said, long-term outpatient care is important. Access to FDA-approved medications, or MAT, which we'll cover later in the presentation. Effective behavioral interventions delivered by trained professionals. Coordinated care for addiction and other conditions, and recovery support services such as mutual aid groups, peer support specialists, and community services. It's important to know that all of these components play a key role in treating the cycle of OUD. As discussed in the first module of this toolkit, Introduction to Opioids, Opioid Use Disorder, opioid use disorder is not a moral weakness. It is a chronic disease. It alters the brain, making it extremely difficult for people to quit, even when the substance, opioids in this case, is destroying their lives. Although many individuals who use opioids try repeatedly to quit, many times their efforts are in vain. Over time, opioids become extremely difficult to go without. Once the brain has been rewired by opioids, a person may feel trapped in a never-ending cycle. The cycle consists of opioid use, withdrawal, so consisting of anxiety, nausea, vomiting, abdominal cramping, diarrhea, sweating, muscle pain, and more, and then cravings, as you see here on the slide. Opioid use, either prescription or illicit, may give a feeling of euphoria. But over time, things that used to be enjoyable can't compete with these euphoric effects. Withdrawal can start just 12 hours after taking opioids and can sometimes last over 2 weeks. Trying to avoid withdrawal symptoms can become all-consuming and drive cravings that trigger continued use. These cravings can be triggered by anything associated with using opioids. Because of the cycle we just learned about, most people cannot recover from opioid use disorder on their own. They need help to return to normal, healthy living. Currently, the most effective approach to treat OUD is called medication-assisted treatment, or MAT. MAT has been researched and found to be highly effective in treating OUD. There are 3 equally important parts to this form of treatment. First is managing and stabilizing opioid withdrawal. The second part is medication maintenance, using one of three medications, buprenorphine, methadone, and/or naltrexone. The third part of MAT is incorporating counseling or behavioral therapy into the treatment. Underlying health conditions that may be influencing opioid use should also be addressed. In the later phases of MAT treatment, healthcare providers work with patients to determine when the medication can be tapered, slowly decreased over time, or even stopped. It is important to note that long-term treatment is often needed to prevent relapses. The National Institute on Drug Abuse emphasizes that these medications do not substitute one addiction for another, which is a very common misconception. The medications used are longer-acting opioid-based medication that actually reduce opioid cravings and withdrawal and help restore balance to the brain circuits affected by addiction. We'll learn more about each of these three medications later in the presentation, but first, let's take a look at the history of medication-assisted treatment. Medication-assisted treatment for opioid use disorder has been around for a number of years. In 1956, Dr. Marie E. Neiswander, the author of The Drug Addict as a Patient, wrote on the significant number of relapses happening in those people attempting abstinence from opioids without medication, despite detoxifications, hospitalizations, and even psychotherapy. She went on to say that maintenance using opioid medications could be used for extended periods to help with the overall functioning of these patients. Then, a couple of years later, in 1958, a joint committee of the American Bar Association and the American Medical Association issued a report recommending that an outpatient facility prescribing opioids to treat OUD be established on a controlled experimental basis. Next, in 1962, Dr. Vincent P. Dole, a specialist in metabolism at Rockefeller University, studying the scientific, public health, and social ramifications of addiction in New York, received a grant to investigate the feasibility of using opioid maintenance as a treatment and recovery option. Then, in 1964, Dr. Neiswander joined Dr. Dole's research staff along with many others. What they discovered showed that short-acting opioids such as morphine, heroin, codeine, oxycodone were not a good choice as opioid maintenance drugs because patients' social functioning was impaired by the sedating effects. Also, the short half-life of these drugs required several injections per day, and as tolerance developed, increasing amounts were needed to remain stable. Because of this, research turned its focus to other longer-acting opioid drugs like methadone. Initial research showed methadone to be safe and effective, and in the early 1970s, methadone maintenance became a major public health initiative to treat opioid addiction under the leadership of Dr. Jerome Jaffe, who headed the Special Action Office for Drug Abuse Prevention in the White House. In the 1980s, the National Institute on Drug Abuse completed initial testing of naltrexone, a non-opioid-based drug to treat opioid addiction, with an approval from the FDA issued in 1984. Some opioid treatment providers have found that naltrexone is most useful for highly motivated patients who have undergone detoxification from opioids and need additional support to avoid relapse. Continuing with the history on MAT, in 1995, naltrexone also received FDA approval as a preventative treatment for relapse to alcohol use among patients dependent on alcohol, and 2 years later, the National Institutes of Health consensus panel called for expansion of methadone maintenance treatment. The Drug Addiction Treatment Act of 2000 was passed, allowing qualifying practitioners to dispense or prescribe the medications approved by FDA for MAT. Buprenorphine became FDA approved in 2002 and was the first opioid-based drug approved for treatment of opioid addiction in a physician's office setting. A year later, an interim rule change made buprenorphine available for use in opioid treatment programs that are certified by SAMHSA. To date, there are 1,836 opioid treatment program facilities in the U.S. 4 of those are here in Montana. and 51,974 buprenorphine waivered practitioners in the U.S. 50 of those reside in Montana. MAT can be incorporated into a treatment plan with or without the aspect of counseling and or behavioral therapies. This happens one of two ways. We'll learn about those on the next slides. There are two settings in which MAT can be administered. The first is through opioid treatment programs, or OTPs. OTPs are outpatient programs that provide comprehensive or integrated treatment services, including pharmacological treatment for OUD. MAT patients treated in OTP facilities are required and must receive counseling, which can include different forms of behavioral therapy. These facilities are accredited by SAMHSA, licensed to operate by the state where located, and registered with the U.S. Drug Enforcement Administration. The MAT medications administered at OTPs include methadone, buprenorphine, Suboxone, which is a combination of buprenorphine and naloxone, and Vivitrol, or naltrexone. We will discuss these medications in more depth in the coming slides. So initially, patients go to the clinic 6 days a week for evaluation and observed dosing, and there is no limit on the number of patients who can be treated in an opioid treatment program facility. On the right hand of the slide, you'll see there's information on office-based opioid treatment, which pertains to treatment occurring via primary care and general health settings, and in some specialty practices. In this case, patients are seen by a medical provider with a Drug Addiction Treatment Act waiver. This waiver allows the provider to prescribe buprenorphine, Suboxone, a combination of buprenorphine and naloxone, and naltrexone. These patients fill prescriptions at the pharmacy of their choice. Prescriptions are often written for a 28-day supply and can have up to 5 refills. So unlike OTP facilities, the OBOTs are not permitted to prescribe methadone. And although recommended for improved outcomes, there is no federal requirement for counseling when patients use OBOT. In April of 2021, the U.S. Department of Health and Human Services waived the training requirements for providers who wish to prescribe buprenorphine and not exceed 30 patients, meaning they cannot exceed seeing 30 patients at a time. Although no waiver training is required, all providers must still apply for the waiver but choose Notice of Intent, NOI, which does not require the waiver qualifying training, but rather specifies their intent to receive training if after 1 year the provider wishes to increase to 100 patients and 275 patients in year 2. There is one exception to the waiver requirement, referred to this as the 3-day rule. The rule will be explained in detail on the slides to come. Here on the slide, you see a table that breaks down the FDA-approved medications by brand names, which you'll see in the middle column, and the street names that may be associated with them. You'll see that on the column to the right. These medications are opioid-based medications and include methadone, buprenorphine, and buprenorphine with naloxone. Naltrexone, which is the non-opioid medication, is also used in the treatment of OUD. It works differently in the body than buprenorphine and methadone. And here you see the name on the left-hand column, the brand name, and then the street name, which in this case is unknown. So this brings us to our next few slides where we discuss how some of these medications work in the body. So let's start with methadone. Methadone is considered a full opioid agonist medication, which means they are substances initiate a physiological response when combined with a receptor. They work similarly to other opioids such as heroin, morphine, or fentanyl. However, unlike other opioids, methadone acts much more slowly in the body. This slower action helps to reduce the euphoric highs and lows that normally occur when using other types of opioids. And because it acts so slowly, it diminishes withdrawal symptoms. Methadone treatment is available only through a licensed and federally regulated opioid treatment program, or the OTP, that we learned about on a couple of slides ago, and requires those in the program to report to the OTP daily or near daily to obtain the medication. It is important to point out that not all MAT clinics are OTP clinics and therefore cannot prescribe methadone. Methadone itself certainly can be addictive and misused, so it's important that it be used only as prescribed and under medical supervision. Let's talk about buprenorphine next. Buprenorphine is a partial agonist, meaning it binds to the same opioid receptors but activates them less strongly than a full agonist like methadone. It suppresses and reduces cravings, lessens withdrawal, and blocks the euphoric effects of opioids. When taken as prescribed, it lowers the potential for misuse. As you'll remember from the history slides, buprenorphine was the first medication used to treat opioid use disorder that can be prescribed or dispensed in a physician's office. This significantly increased access to treatment options. Upon completion of specialized training, the Drug Addiction Treatment Act of 2000, the Comprehensive Addiction and Recovery Act, and the Substance Use Disorder Prevention, Opioid Recovery, and Treatment for Patients and Communities Act allows qualified practitioners to dispense or prescribe buprenorphine for the treatment of opioid use disorder in settings other than opioid treatment programs. As mentioned, this training is called a Drug Addiction Treatment Act waiver, or sometimes referred to as the buprenorphine waiver. As you'll recall from the timeline, the Drug Addiction Treatment Act of 2000 was passed, allowing qualified physicians to obtain a waiver to treat OUD with buprenorphine in primary care settings. Such waivers may make this treatment more accessible to those seeking treatment. Like methadone, it's possible for buprenorphine to be misused when not taken as prescribed. SAMHSA provides buprenorphine waiver certifications. SAMHSA waivered practitioners who are certified in prescribing buprenorphine can be found on the SAMHSA website. In addition, buprenorphine is also administered at SAMHSA certified opioid treatment programs. SAMHSA maintains a list of these certified or accredited opioid treatment programs on their website. It's also important to know that buprenorphine can be combined with naloxone. Naloxone is what's known as a non-selective and non-competitive opioid antagonist. It works by reversing the depression of the central nervous system and respiratory system caused by opioids. It blocks opioid receptor sites, which in turn helps to reverse the effects of the overdose. When combined with buprenorphine, this medication is called Suboxone. It interferes with or inhibits the physiological response in the body. Naloxone and Suboxone are two examples of antagonists. Naltrexone is also an opioid antagonist that blocks the euphoric, physiological, and sedative effects of opioids and reduces the cravings for opioids. It works differently in the body than buprenorphine and methadone because it is not an opioid-based medication. While buprenorphine and methadone activate opioid receptors in the body that suppress cravings, naltrexone binds and blocks opioid receptors and is reported to reduce rather than suppress opioid cravings. There is no abuse and diversion potential with naltrexone. This medication may also be prescribed outside of the opioid treatment program. So now it's time to watch a video all together. The Partnership for Drug-Free Kids YouTube channel, called the Partnership to End Addiction, discusses how addiction is a brain disease and can be successfully treated with medication-assisted treatment, or MAT. It explains that medications such as naltrexone, methadone, and Suboxone can normalize and stabilize the brain and improve brain function so that recovery can be met. So we'll take 5 minutes here to watch this video. Though like any medication, MAT medications certainly can have side effects. All the information on this slide is made available by the CDC. But here on the slide, you see the 4 different drugs that we just went over: methadone, buprenorphine, the combination of buprenorphine and naloxone and naltrexone. You see the formulation of these medications on the middle column, and then on the right, we go through the side effects. So we'll just go over one, and then please take some time to read the slide on your own. So buprenorphine, for example, can cause the following side effects: constipation, nausea, vomiting, headache, drowsiness, sedation, insomnia, lack of energy, and weakness. So the question now becomes, can these side effects cause impairments? Research has shown that when provided at the proper dose, medications used to treat OUD have no adverse effects on a person's intelligence, mental capability, physical function, or employability. However, side effects of the medication certainly can impair a person's ability to drive, operate heavy machinery, or perform other functions safely. Side effects will certainly vary depending on the specific medication, dosage, and duration of treatment. Workers with safety-sensitive jobs may be subject to restrictions or limits on the job or duties they perform while using these medications. These restrictions may include operating motor vehicles, forklifts, cranes, other type of heavy equipment, or making decisions that can affect the safety and health of others, such as those who hold jobs as dispatchers, operation managers, or other jobs requiring high levels of cognitive function or judgment. Case-by-case determinations by qualified occupational healthcare providers may be necessary based on the potential for impairment resulting from these medications. Reasonable accommodations by the employer should be considered when appropriate. When starting a MAT treatment program, the worker should avoid driving and other hazardous work activities until dosages are stabilized, side effects are managed, and impairment risk related to the work being performed are assessed. It is also important to note that side effects often diminish over time. The length of MAT treatment is highly variable with all three of the FDA-approved opioid use disorder treatment medications and can span anywhere from months to years. Long-term treatment is often needed to prevent relapses. A decision to taper off medication depends on factors such as compliance, tolerance, adverse effects, and a patient's progress toward abstinence from opioids. Tapering off often takes several months, and removing someone abruptly or prematurely from the medications used to treat OUD may actually increase the risk of relapse and subsequent overdose. Though no matter the length of treatment or approach, the goal of MAT is recovery, including the ability to live a self-directed life. MAT has been shown to improve patient survival, increase retention and treatment, decrease illicit opioid use and other criminal activity among people with substance use disorders, increase patients' ability to gain and maintain employment, and improve birth outcomes among women who have substance use disorders and are pregnant. On the next few slides, we'll discuss the types of intervention approaches that have been proven to treat substance use disorders like opioid use disorder and help sustain recovery. We'll talk about integrated healthcare, early intervention delivery method, recovery-oriented systems of care recovery approach, family support, and peer-based recovery support. When medicated assistant treatment takes place in an opioid treatment program, it requires the integration of many support and care systems. This is an example of an integrated healthcare approach. This approach uses a team of primary care and behavioral health clinicians that work together with patients and their families and is becoming the gold standard across cultures. Integrated healthcare approaches like MAT address mental health and substance use disorders, along with health behaviors, including how these behaviors contribute to chronic medical illness, life stressors and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. Screening, brief intervention, and referral to treatment is an approach to the delivery of early intervention and treatment to people with substance use disorders and those at risk of developing these disorders. According to SAMHSA, screening aids in quickly assessing the severity of substance use identifies the appropriate level of treatment. Brief intervention focuses on increasing insight and awareness regarding substance use and motivation towards behavioral change, and referral refers to the referral to treatment provides those identified as needing more extensive treatment with access to specialty care. A 2017 study of 11 programs serving over 1 million people found an 80% reduction in self-reported illicit substance use, including opioid use, following this type of intervention that has a screening, brief intervention, and referral to treatment peace. Another approach that uses an early intervention method is called Recovery-Oriented System of Care. ROSC is a coordinated network of community-based services and supports that are person-centered and build on the strength and resilience of individuals, families, and communities to achieve abstinence and improved health, wellness, and quality of life for those with or at risk of substance use disorders like OUD. By design, ROSC provides individuals and families with more options with which to make informed decisions regarding their care. Services are designed to be accessible, welcoming, and easy to navigate. A fundamental value of ROSC is the involvement of people in recovery, involvement of their families, and the community to continually improve access to services that are high quality and quality of services. The central focus of ROSC is to create an infrastructure or system of care with existing resources to effectively address the full range of substance use issues within communities. The establishment of ROSC is a relatively new concept in the substance use disorder field. The table you see here on the slide gives examples of the four ROSC activities: prevention, intervention, treatment, and post-treatment or recovery. So you'll see the examples of prevention are early screening before onset, collaboration with other systems like child welfare, Veterans Affairs, stigma reduction activities, or referring to intervention treatment services. So take a minute to read the other columns. Our ROSC supports the premise that there are many pathways to recovery. Recovery-oriented activities include providing a menu of traditional treatment services and alternative therapies, including peer recovery coaching, acupuncture, meditation, and music and art therapy. Recovery support services, including employment assistance, childcare, care management, and housing support, may enhance the engagement of individuals and their families in achieving and sustaining recovery. As you saw on the last slide, family support programs are a very important part of ROSC. The process of recovery is supported through relationships and social networks. This often involves family members who become the champions of their loved one's recovery. Family support programs promote hope and belief that these challenges and conditions can be overcome. Help people in recovery be active agents of change in their lives, not passive recipients of services, and family support can help those in recovery find ways to rejoin and rebuild life in their community. Another approach to recovery is called peer-based recovery support, which is the process of giving and receiving non-professional, non-clinical assistance to achieve long-term recovery from severe alcohol and/or other drug-related problems like OUD. Peer support workers are people who have been successful in the recovery process themselves, who help others experiencing similar situations. Through shared understanding, respect, and mutual empowerment, peer support workers help people become and stay engaged in the recovery process, which can reduce the likelihood of relapse. Peer support services can effectively extend the reach of treatment beyond the clinical setting into the everyday environment of those seeking a successful, sustained recovery process. This support is provided by people who are experientially credentialed to assist others in initiating recovery, maintaining recovery, and enhancing the quality of personal and family life in long-term recovery. So the Substance Abuse and Mental Health Service Administration, or SAMHSA, maintains a list of OUD treatment providers for OUD by state. To find providers in Montana, please visit this website. And if you have time, during this bonus module, now as you're all listening, I encourage you to click on the site and scroll around and see who's around in all the corners of Montana. The Montana Department of Public Health and Human Services also has a very intuitive substance use disorder treatment provider location website with an interactive map. This website will direct you to state-approved SUD providers, inpatient services, outpatient services, recovery homes, and opioid federally funded facilities. Residential or inpatient treatment provides care for individuals struggling with a substance use disorder. These facilities are located throughout Montana and are owned and operated by multiple state-approved treatment programs. The recovery homes that you'll see on the map serve either adult men or women who need a structured, safe, and drug-free living environment. All homes promote lifelong recovery skills, work skills for gainful employment, and assist residents to transition back to independent living in the community as a recovering individual. On the map, you'll also see non-hospital inpatient residential facilities, which provide 24-hour medically or clinically monitored intensive inpatient care. All of this is accredited by the American Society of Addiction Medicine. All facilities focus on withdrawal management, medical stabilization, and provide a highly structured environment to assist in the development of recovery skills. So this concludes our bonus module. For more information on prescription opioid use and misuse in Montana, you can visit our project website. You'll see the website link on the top of your slide. Our website will allow you to access the other 4 modules and all the PowerPoint presentations. We also have a Native American toolkit that you can access on the website and watch several informational and recovery story videos. You can also print and download our educational resources and order a medication disposal pouch while supplies last. If you have any questions whatsoever, or if you know of an organization that would benefit from this toolkit or would like to present the toolkit to their communities, please email our program director, Barbara Allen. You'll see her email on the slide. Also, please visit the Montana Department of Health and Human Services website. Thank you very much for listening today. We hope you have gained a deeper understanding of treatment and recovery approaches to OUD and have increased your overall knowledge and awareness on the topic of prescription opioid use and misuse. Thank you.